Hello everyone, I'm here doing my clinical issue presentation for the NCU blueprint for our class over geriatrics. I had a lot of questions on my C exam and future board exam. I'm sure we'll have a lot of questions over geriatrics, so I thought this would be a good topic to go over. As most of you know, we take care of a lot of older people and it's only going to increase over time. So our first slide, we're looking at increasing population of geriatrics. By year 2040, 24% of the population is expected to be over 65, and that's a lot considering that those are most of the surgical clients that we have, and it's going to account for 50% of our healthcare expenditure. The combined cost of Medicare and Social Security is predicted to grow from 8.4% to 11.2% gross domestic product as the number of elderly people comprises of 20% by 2030. As we know, as you get older, things work a little less, and so you have a higher incidence of coexisting problems leading to increased healthcare needs, different specialties, surgery being one of those, and they come see us in anesthesia. And it's our job to be vigilant enough to know the differences and know how to take care of these safely and effectively, as that's what we're trained to do. I got a chart here, it just shows the increasing age. So in 1950, the median life expectancy was about 68, and say now 2015 to 2020 it's 80, and it's only by 2050 it's supposed to be 83 years old. So 50 years ago people weren't living past their 70s, and now they're living almost to 80 years old, meaning that's basically an extra 10 years to take care of these people, medicines, surgery, all kinds of things. So we're going to look at some changes associated with aging, as this is what seems like I was tested over a bunch, was differences in, each organ system for, say, a 20-year-old versus an 80-year-old. What do you need to be mindful of? What do you need to look out for? And what do you need to be prepared for during your anesthesia case? We're going to look at normal changes versus pathological findings, concentrating mostly on normal changes seen with aging, because if we went into pathologic, we could be here all day. So we're just going to talk about how the heart changes and blood vessels and respiratory work of breathing, everything like that. So aging is defined as a progressive loss of functional reserve in organ systems, roughly 1% decline in organ function each year after 30. So by 70, you have a 40% decline in organ function, basically. So first system we're going to look at is the cardiovascular system. Just some normal changes, increase afterload, which you see all the time. Older people come to the OR and they got their normal blood pressure is like 150, 160. You got an increased afterload because arterial compliance decreases because the elasticity increases. It's just not able to vasodilate or vasoconstrict because of they lost their compliance. What that leads to is increased systolic blood pressure. Left ventricular hypertrophy is a normal finding associated with aging. Decreased adrenergic activity. They have decreased circulating catecholamines, and their response to catecholamines is decreased. Their vagal tone is decreased. And they also have a decreased cardiac reserve. So associated with the adrenergic decrease, they have baroreceptors just like me and you do, but they have a lot less reflex. They don't have as much change in association with baroreceptors. So the cardiac reserve, that's why you see a decrease in blood pressure with induction a lot steeper than with a normal healthy person or a younger person. It's because you give them a big whopping dose of propofol, they don't have the cardiac reserve to be able to handle that change. Circulation time, I know we've all seen this. You give drugs and you have to wait, seems like forever in anesthesia time till they go to sleep or till your paralytic starts working. Their circulation times are decreased. Conduction fibrosis, so they have a higher incidence of arrhythmias. So some pathological findings, atherosclerosis is not a normal finding, whereas increased blood pressure is a normal finding. Coronary artery disease is not a normal finding. Essential hypertension is abnormal. CHF, abnormal pathological finding. Arrhythmias due to the conduction system fibrosis, and it loses SA node cells, and that's what leads to dysrhythmias. Aortic stenosis, also a pathological finding. All these things need to be aware of that have higher incidence in elderly people. Next, we're going to talk about the respiratory system. So respiratory system goes through a lot of changes, mostly with lung volumes and capacities, and we'll talk about that in the next slide. Some increase is our residual volume, closing capacity. They have a VQ mismatch, increased chest wall rigidity, and they also have an increased risk for aspiration. So the aspiration comes in because they have a progressive loss in protective laryngeal reflexes, and they have some immunocompetence. They're just not able to fight infections like they used to be able to. That's why you see a lot of times whenever elderly people get UTIs, they don't have that many signs and symptoms, and one of them they don't have is fever, because they just don't have the immune system that ramps up to fight UTIs or infections, so their risk for aspiration and aspiration pneumonitis is higher. So they do have decreases in pulmonary elasticity, and they have decreased alveolar surface area, which causes some decreased arterial oxygen tension. They have a decreased cough effort, leading to, again, risk for aspiration and, unable to protect that airway. It's just something to be mindful of when you extubate patients, elderly patients particularly, that good suction, making sure they're good and awake enough to protect their own airway reflex so that they don't aspirate. They have a decreased response to hypoxia and hypercapnia, so they can get hypercapnic, maybe CO2 narcosis easier, and or hypoxic easier, because they just have less of it just causes less stimulus for them to breathe. So residual volume, this increase here causes, it's so much so that the FRC increases past closing capacity, where you're blowing out. It actually exceeds FRC, which is important because they have a lot of air trapping. One thing I was going to talk about was the work of breathing. Skeletal calcifications that increase airway resistance increases the work of breathing in subjects who are elderly and predisposes them to acute postoperative ventilatory failure. So it's just when you're waking up and thinking about extubating and looking at their ability to breathe, or they don't have any residual muscle relaxation, don't want to be too sedated. It's because their work of breathing is already predisposed for problems. So just think about that whenever we're all practicing. On the next page, it's talking about lung volumes and capacity. So if you remember your incentive spirometry wave, so increases residual volume, FRC, and closing capacity, and decreases in expiratory reserve volume. So they're just not able to blow out as much volume, which leads to the air trapping. Inspiratory capacities decrease and vital capacities decrease. But all that being said, the actual total lung volume, your total lung capacity, does not change, which is interesting. Next, look at nervous system, peripheral nerves, central nervous system. They have increases in muscle atrophy. This is supposed to be on the other side. This is increased hearing loss, so it would be a decreased hearing. They have a decreased temperature threshold, just not able to hold their temperature or regulate temperature as much. Vision thresholds, they're not able to see as well. Subarachnoid duration of action is increased, and the sensory block is decreased. And epidural volume has a higher incidence of cephalad spread, so just something to think about if you do any epidurals for knees or ortho stuff, or anything for that matter. They do have a decreased cerebral blood flow, decreased intracranial volume, gray matter and brain mass both decrease. That's why you see atrophied brains mostly, and a lot of times in Alzheimer's and dementia. Decreased muscle strength, that's something to think about with extubation and chicken hand strength and able to lift their head and things like that. Decreased skeletal muscle control. They have a decreased local anesthetic dose needed, but they have as opposed to increased duration of subarachnoid block, they have a decreased duration of epidural block and decreased epidural motor block. And then, as we all know, their dose of follow agent they need is decreased, as we all see that every day. So one thing I want to talk about is postoperative cognitive dysfunction. This is that kind of delirium state that they can have postoperatively. It's not delirium, but it's just kind of a comparative term. Up to 30% of elderly patients can demonstrate abnormal neurobehavioral testing within the first week after an operation. Not yet determined if general anesthesia is the cause. It's looked at to be multifactorial through drug effects, pain, underlying neurological conditions that may not have been diagnosed yet, but we're on the verge of surfacing. Hypothermia can play a major factor as their temperature regulations impaired. The surgical procedure, as cardiac surgery and major orthopedic surgeries, big hips and femurs and such are causes. Renal function, as we all know, the kidneys function goes down pretty much every year as you age. Your creatinine clearance, and this is kind of an interesting thing to note, could be a test question. Creatinine clearance decreases and GFR decreases, but your actually serum creatinine is about the same because of the decreased muscle mass. So if they say what decreases in aging, it would not be serum creatinine, but it would be creatinine clearance and GFR. Kidney mass decreases, renal blood flow decreases, and that's why you need to be vigilant about urine output in bigger cases with older people. They have trouble handling fluid and sodium. They can't concentrate their urine as well. They have increased risk for dehydration and overload. Decreased response to hormones such as ADH and aldosterone. One thing I've starred here is important is decreased clearance of hydrophilic agents and metabolites. Just remembering what drugs are secreted in the urine. Some muscle relaxants to be aware of, and the just drug dosages when you think about elimination of those. They also have a increased risk of being hyperkalemic and hypokalemic because they can't really regulate their potassium as well as they used to be able to. Next, some metabolic changes. This is kind of GI liver stuff. It's mostly the liver for anesthesia considerations. The basal and maximal oxygen consumption declines. Heat production decreases and heat loss increases. So they, like I was saying, they can't regulate their temperature. They have increased insulin resistance, so higher incidence of diabetes. They can't metabolize benzodiazepines. As most of you know, you always decrease your dose of benzos as you don't want it staying around with them. You're not going to have an 80-year-old you give a big old whopping dose of 5 milligrams of Versed for an hour-long case, as it's going to take forever to get rid of. Decreased plasma cholinesterase. They also have decreased hepatic blood flow and hepatic function declines in relation to liver mass. So the function actually is the same and doesn't decline. So if you have a question to ask about that, it only declines as the liver size decreases. The most important thing is that it has to have decreased hepatic blood flow. So if drugs are not being metabolized and you're worried about that, it's usually because of the decreased hepatic blood flow. That's why I wrote impaired ability to metabolize non-depolarizers. Delayed gastric emptying, important for MPO status, and then decreased albumin production. Nutrition is a huge factor. I think I wrote it on the next slide. Going along with that, albumin. Serum albumin less than 3, it's at the bottom here. Malnutrition, significant for post-op mortality, 30 days and up to 1 year. Because it's such an important part, having those plasma proteins and maintaining a good diet for healing and just staying healthy. So some preoperative anesthesia considerations. Be patient specific. I was reading this in the book. Make it directed by surgical procedure, past medical history, and physical exam. Just don't order all these labs and x-rays and everything, have a purpose for ordering things, EKGs, echoes, if these are some things that need to be done. You don't just blanketly order things, it seems like we all say, oh, they're over 40 or 50, they need to be EKG before. It's not standard of care, but it should be based on, patient, each patient. Most important part's a good history and exam, and that would lead you into preoperative testing. Best predictor of postoperative function is your preoperative function, so you're not going to bring somebody that's super sick and bring them in and cure everything and send them out. Anesthesia, we want to bring them in and send them out the same or a little better if we can than when they came in. METS evaluation is really important for looking at their exercise capacity and ability to handle stress on their heart, lungs. Pulmonary evaluation, important is pulmonary hypoxia is 20 to 60% incidence in elderly patients. And then I already talked about malnutrition. So some intraoperative considerations. I've touched on the drug, on some drug changes, but progressive decrease in muscle mass, you're going to have increased fat, decreased water. So you have a smaller volume distribution for water-soluble drugs and larger for lipid-soluble. It's because these people are dry and they just don't have much total body water anymore. Increased circ time I touched on. MAC is reduced 4 to 6% per decade after 40 years old. And that you have something to remember is you have a more rapid uptake of volatile agent with decreased cardiac output. So some other considerations: your choice of anesthetic will be based on it's multifactorial, based on surgery, patient preference, provider experience. That's going to be us. We graduate in a couple months, and if the safer thing is to do some block you've never done before and do a lateral spinal and lay them there for it's like that is the best technique if you're comfortable with doing that, but it needs to be something, consider your experience and what you're good at. Your best general may be better than a limp through spine, lateral spinal or block that doesn't work, something like that. Sometimes these elderly patients aren't the best ones to practice on a new anesthetic technique. And also the patient physical status, if they're healthy, have a bunch of comorbidities or whatever. Standard monitors, there's no need for invasive lines unless indicated by the patient for sickness, or if it's a big surgery, major blood loss, expected, thoracic surgery, something like that. Careful positioning is really important. They have soft bones and can have a higher injury chance. Protect soft tissue because it has decreased blood flow. So if you have a pressure spot, they can get ischemic a lot easier than a younger person with better subcutaneous blood flow. These patients are chronically dehydrated, need volume assessment before surgery. Protect from hypothermia, prevent shivering as that increases oxygen consumption. So a research article I looked up, just looking at some things on geriatric patients, was comparison of use of sevoflurane and remifentanil compared to propofol and remifentanil anesthesia. These are just urological procedures done on geriatric patients. So they measured all these things as far as recovery goes, discharge from PACU. They used a certain scale to measure how awake they were and could response and all those things. And basically everything was about the same except for extubation time was significantly shorter in patients with propofol and remi. They were able to extubate them faster, but what was funny was that responses to verbal commands and orientation was similar. So I guess they would extubate them before they were actually responding to verbal commands, or else the time wouldn't have been significantly shorter. Patients were evaluated for recovery times, and PACU discharge times were about the same. The study concluded that both anesthesia methods were pretty much the same except for extubation, but full recovery they were very similar. They actually thought that propofol might be longer for longer cases as it would accumulate, as opposed to a volatile agent coming off faster than that. So just to summarize, Aging is a multifactorial, all-encompassing process. It produces gradual decline in functional reserve of most major organ systems, which results in a decreased capacity for adaptation. So for us, a sound understanding of aging, related physiological changes, and altered pharmacokinetic and pharmacodynamic responses of these patients helps the CRNA design and implement an optimal anesthetic plan for each elderly patients. Since this patient subgroup is not only physiologically but also physically fragile, these patients require special attention throughout the perioperative period to prolong life and maintain good function and quality of living. And here's my references, and thank you.